Thank you. I was in the earlier conversation in introducing us to Minnesota, which was highly educational for me. My only response is that I am from the Great Lakes state. So I just wanted to say that out front. But I'm very happy to be here. Thank you to Respecting Choices for the invitation and for a commitment to sort of getting down in the weeds with something as, thrilling and engaging as professional fee billing, but really important to the missions of your organizations as well. I also want to give Sandy special thanks both for this scientific programming of this meeting, which is fantastic, and also your help to me in putting this together. So we're really a great program. So yes, so we have a big room and a great, small, I'm sure, engaged group. I'm going to try to make sure that we meet your needs. And actually, we're small enough here that I want to start by maybe talking a little bit together. So by a show of hands, how many folks are billing for advanced care planning services in your practices? We have 1 and maybe a quarter, a tenth, 1 and a quarter. And some folks are not. I saw some nods. Why are you not billing? Okay. Okay. Excellent. Okay. Fantastic. And then, ma'am, and that. Yep. Important. Right.
That be co-location for those individuals, and the logistics just became a nightmare for us because we're a large system.
Okay. So important. So heard a couple of things. One is learning that this opportunity is available and perhaps engaging. And the other is understanding the opportunity, but thinking that your particular organization isn't able to take advantage of it because of operational needs and actually a respect for out-of-pocket costs for patients and families. Great input. Any others? Okay, so sort of being not engaging in early adoption and sort of being able to take advantage of processes that may develop to do this more easily and efficiently.
Get the ACP embedded into their standard practice.
Okay.
Then they figured they would roll it out and bill for it.
So get the practice going first and the service delivery going first, and then add in the billing piece. That makes sense. Other folks with experience to share. Yes.
Can you wait for that?
So from January 1st to September 30th, we had the CPT codes used only 15 times.
Okay.
But now we are moving into bundled payments, care improvement advanced, with ACP as one of the initiatives that we should be discussing, and trying to figure out how we are going to, the proof is in the billing for bundled payments related to ACP, and how we're going to incorporate those codes in billing and bundled payments and working that all together.
So maybe looking to increase significantly the frequency with which you're
That's exactly right.
Codes. And you did really a fantastic strategic move of what we sometimes call riding the horse the way it's running, which is easy, right? So getting on an initiative that your organization is investing heavily in, like the BPCI, and using that to expand the work that your team's doing. Great.
Exactly.
Fantastic. I want you to come work for us. Okay, so I'm looking forward to going through just a couple of things up front. I have a lot of slides that have a lot of words on them, and they're all in your packet. You'll notice if you're looking closely, they look a bit different on the screen than they do in your packet. We've just done some formatting to make them appear a bit friendlier on the screen. There is one important content change that I will highlight when we get there on slide 17. My disclosures, I serve the American Academy of Hospice and Palliative Medicine and other organizations in a variety of unpaid volunteer positions related to payment. I'm also very grateful to the Canby Foundation to receive support as a Sojourn Scholar. So Sandy mentioned up front, there's going to be a couple of opportunities this morning to talk about billing. This first session, which is largely informational, and then a workshop that follows. The material you'll see today will be repeated in the next section. So if you're thinking about how to use your time most wisely, know that. So 2 basic learning outcomes. I'm going to kind of spend a little bit of time walking through the fundamentals of the ACP codes, right, as folks are learning about the opportunities, but beginning to get your heads around how this would work in your practices. And then actually think specifically about your practice setting. And we'll spend some time talking about some issues that have come up frequently when we talk to organizations and systems who have implemented the respecting choices model. And as we move through, we're a small enough group here. If you've got questions, please feel free to shoot your hand up in the air. We can sort of adapt the pace and the flow to meet your needs. Oh, great. And then I will do my best to wait for the person to get there to test them to speak. Okay. Briefly about the history of the ACP Codes. So if any of you remember those Schoolhouse Rock Saturday morning cartoons, like the one that's in my head is the one about the bill, like I'm just a bill and I'm only a bill. So CPT codes actually have an analogous journey from their inception to being put into use and being paid. And I'm not going to go through the process, but the ACP codes as they stand today actually started back in 2013. The Illinois State Medical Society actually wanted to create a mechanism to receive payment for advanced care planning services. This happened a little bit in reaction to the unfortunate circumstances around the Affordable Care Act back in 2009. Some of you may remember that there was a provision in the Affordable Care Act that would provide the voluntary advanced care planning to Medicare beneficiaries, famously torpedoed by a tweet from Sarah Palin about death panels, which we won't relive. This was in a way to sort of come back and find another path, and ultimately, frankly, would be a more sustainable path than what had been proposed in the ACA. So we're grateful for that. The CPT editorial panel is the group that creates the codes. That there's a separate committee called the RUC, the Relative Value Scale Update Committee, the most important committee you've never heard of, which recommends RVU values to CMS. Historically, that were accepted almost lock, stock, and barrel. There's now a bit more oversight to that. The RUC did value the codes. We'll talk about what the values are. And ultimately, as of January 1, 2016, Medicare is making payment for ACP codes. So what is the payment? So are folks familiar with the term RVU? Relative value units? I'm seeing nodding. So these are ways to describe the professional work of healthcare. Every one of the 10,000 CPT codes has an RVU associated with it, and the RVUs for advanced care planning services are followed. For 99497, which as you'll see covers the first 30 minutes of advanced care planning services, it's 1.5 RVUs. Depending on where you are in the country, it's about $86, something like that. And then actually a very similar payment for each additional 30 minutes. I want to talk a little, just jump a bit ahead to talk about the uptake of these codes, right? So this is a very busy slide. I apologize for the small font, but this is meant to compare frequency of code reporting from 2016 to 2018. So it gives kind of a little bit of a snapshot of how many people are using the advanced care planning codes. And this work, by the way, was done by CTAC, published on their website. Marian Grant and her group did great work to get this out. I'll just make 2 points about this. You'll see some very, this isn't going to point, I'm sorry. So if you look at the number and percent of total Medicare beneficiaries comparing 2016 to 2018, you'll see the numbers are small, sort of 0.48% to 0.78%. However, they've nearly doubled in 2 years. I will tell you, this is like rocket fuel for new CPT codes. When new codes are introduced, especially for services that have not previously been delivered, it takes a very long time for things like providers to know that the codes are available, for billers to develop the infrastructure around it. So there was some pent-up demand for this, and it's continued to grow. So we're actually very excited about the uptake of the codes and hope to continue to spread the work. I will say as part of the RUC process, we needed to project the expected volume of services over time. And we felt conservatively that this particular service, which is actually a fairly intense kind of advanced care planning, which we'll talk about a little bit, would affect about 1% of beneficiaries. And we're about 3/4 of the way there. So, what do the codes say? So these are the descriptors, and this is what exists in CPT, and this is what the codes say. And I don't often read slides, but I'll read this one because it's important. So 99497, advanced care planning, including the explanation and discussion of advanced directives, such as standard forms, including the completion of such forms when performed by the physician or other qualified health professional, first 30 minutes face-to-face with the patient, family members, and/or surrogate. So what strikes you about this code descriptor? Anything? Anything in there about being seriously ill? Anything in there about shared decision-making? Anything? So this is incredibly sort of generally written. And this was frankly my first introduction to CPT language writing, which is an art form. It's like haiku, right? It's the minimum number of words possible to describe the service that you want to be able to then get paid to do. What this allows us to do is actually think pretty broadly and apply this code across a whole set of different kinds of services. Everything from a, otherwise healthy adult who has an interest in having a detailed discussion about what matters most to them and how to document that in a way that can help them to get the care that meets their needs when the time comes, to someone with advanced heart failure, liver failure, dementia with a surrogate, to have very in-depth, kind of long conversations about executing those plans when the time comes. So I think this is actually makes this a pretty versatile opportunity for us to use this across the course of our patients' journeys. So I've highlighted a couple things here. One is explanation and discussion. So this service is really about the conversation, and I don't have to sort of sell that in this room. This is what you're all here for. This is what you do. This is what you implement. I've also highlighted physician or other qualified health professional. And I did this because CPT services codes as paid through Medicare can only be paid for services delivered by physicians or other qualified health professionals. That typically includes advanced practice professionals, advanced practice nurses, PAs, working under the licensure of the individual states. There is a provision called Incident 2 services that we'll talk about in some detail, and I say this here because many groups who have implemented the respecting choices model are having the services delivered expertly by people who can't bill for them today. There are some ways to get around that we'll talk about, but that's why I highlighted it. Yes, so we will get to that. And then last, patient, family members, and/or surrogate. This is something that we actually work really hard to get in the descriptor, which is the idea that, we know that patients, especially as they become more seriously ill, sometimes earlier if they have cognitive decline, are not able to have these conversations themselves, and their surrogates need to be involved in the discussion. So the time spent talking to a surrogate, legally defined or otherwise, can be counted towards the CPT code. When published, Medicare makes no specific requirements for using the ACP codes, right? This is actually not unusual for them for many codes. In the end, the government really doesn't want to be a health plan. They don't want to be in the business of executing payments and making sure people are doing them well. They try to farm that out whenever they can, and the fee schedule sort of reflects that. There may be some rules written in the future depending on how code utilization goes, but now there are no specific requirements, and that leaves us to sort of think about what would be best practices as you're considering using these codes, documenting for them, and then getting paid effectively. So advanced care planning, as described, without any guidance from Medicare, may include some of the things that we've referenced already. So discussion of goals and preferences for care, complex medical decision-making, I would say shared medical decision-making, explanation of relevant advanced directives, including but not requiring completion. That's important, and I didn't stress that up front. You do not need to complete an advanced directive as part of the service in order to bill for the code. And then again, engaging everybody who's important in the conversation, including the patient, of course. Yeah. Sure. Yeah. Yes. I will be patient as well.
You know that Michigan fight song was voted the #1 fight song in the country?
Well, we've always assumed that in Ann Arbor. So
we've always known that, yes.
Question, right? Yes.
Okay, so can you go back a slide?
Sure, of course.
So discussion of goals or preferences for care from a palliative standpoint. Are palliative folks, when they work through goals of care with patients and families, is that a separate bill for them, or what's the coding on that? If they're doing that as part of their scope of practice anyway,
yes,
and they're billing for it, obviously, then do they have to do something in addition to?
Yeah, great question. So the question was, in the course of care for a palliative care team who is doing a lot of this work all the time, is that included in their E&M codes or how they build their daily work? Or is that also eligible to be billed through the vascular planning codes? And the answer to your question is yes. We encourage palliative care teams or anybody taking care of a seriously ill patient, if you have a visit that includes both services that you would perform in a typical evaluation and management visit, management of pain, dyspnea, shortness of breath, treatment for heart failure, treatment for cancer, treatment for an illness that would be definable there, and you are also performing an advanced care planning services that meet the time requirements that we'll talk about, you may bill both. And we're encouraging people to bill both. And this gets down in the weeds a little bit, but I'm happy to with this group. A lot of palliative care teams have come to bill their E&M services based on time. I'm not sure if you guys have done this before or not. So there's options with E&M coding, there's time, and there's complexity. We're actually encouraging palliative care teams to bill their E&M visits on complexity and then build the kind of the goals of care discussions based on time. And that's totally legit to do. So the documentation needs to be discrete for purposes of auditing. And here is where I would definitely encourage you to talk to your institutional coders to understand what their best practices are. At a minimum, the advanced care planning service should be cleanly documented within your note. Best practice, and frankly, what my institution makes us do, is create a second note for the advanced care planning service. That's probably the safest way to do it, to protect yourself against audit. So we just do a progress note or an HMP that would look like, a typical physician visit for the medical issues, and then we do a separate advanced care planning note, which historically we would have been embedded within our consult note. But great question. So to documentation, again, no guidance from Medicare, though I will say we're starting to get a little bit of information back from the regional Medicare administrative contractors, the MACs. Do people know about Medicare administrative contractors? So Medicare is not managed from Washington. The Medicare program subcontracts with a group of corporations that manage regions of the country, and they manage both the payment, all the auditing, all that stuff. So that's important for this because the advanced care planning codes are, the execution of them is sort of left up to each of the audit contractors. Your billers know this, and they know who they are. So I don't encourage you to get involved with your MACs because it's a deep, dark place. But know the people in your organization who do, because they may have some preferences, again, around things like documentation. For example, to just jumping to number 2, these are time-based codes, right? So you choose the code based upon the amount of time you spend with the patient. Some contractors are fine with total time spent. Others like start times and stop times, which is kind of a pain. Not many of them do for these. They do those for the prolonged services codes more than these, but just it is probably worth a conversation. But I would definitely get in the habit of documenting the time spent in advanced care planning. And then also documenting the sort of summary of the discussion. Now, in working with the respecting choices before, this is something that you do. You produce documentation from your conversation. So, I have pretty good confidence that that's going to be robust enough to meet the bar. But the detail in that conversation should vary based upon the complexity, and it should also justify the amount and number of codes that you report. Form completion may or may not occur. You don't have to complete advanced directives. And there's no real diagnosis requirement. So again, you don't have to tag this to a specific serious illness. However, if you are going to be billing significant numbers of these codes or billing them very frequently because a patient's situation is changing, it is probably a good idea to indicate the diagnosis for which you are billing the codes. So we talked about this a little bit. Who can use the codes? Qualified providers as defined by Medicare. And other providers may not report them independently. There is this opportunity to use what we call the incident to requirements that we're actually going to talk about in some detail in just a few minutes. The ACP codes can also be reported for services delivered in any setting. So this is inpatient, this is observation, this is ED, outpatient clinics, skilled nursing facilities, assisted living facilities, home, anywhere. They can be used in what are called hospital outpatient settings. Do people know what that means? Who here works in an office setting, a clinic setting? One person, and you stretching there. This is an important distinction. So the office setting is limited to typically independent, often physician-owned practices or group-owned practices. There's a separate designation called hospital outpatient departments. Those are hospital-owned clinics. The payment systems are different for those two things because the facility payments for the hospital outpatient departments are higher than those for offices. This is part of the reason why many hospitals have bought practices, is that it is a source of revenue. But Medicare does not want to double dip, right? If they're paying you for a higher facility fee, there are different ways that they may bill the codes. Again, this is more of a back-end issue, but it is important with respect to the Incident 2 rules, which is why I dive into the detail here. To your point, sir, in the back, the advanced care planning codes can be billed alongside almost every other evaluation and management service. So the codes that you use to bill your care in the office, in the hospital, in the ED, observations or consults. They can also be billed importantly, and this goes to the important issue of coinsurance and out-of-pocket cost. If the advanced care planning code is billed on the same day as a Medicare annual wellness visit, the copay is waived. And that's to encourage this to be done with Medicare beneficiaries when they're in for the wellness visit, they're thinking about planning. And then you just need to use a modifier 33. Yes? Go ahead.
I got to back up just a minute. I thought you were going to cover something. But
Sure.
So one more slide.
Yes.
So all other providers, social work, psychology, chaplains, they don't report the code, but it's my understanding that if they're working under the supervision or the auspices of a qualified biller,
Yes.
that the biller can bill for their work.
Correct. That's the incident to billing that we're going to talk about in about 2 slides.
Oh, never mind.
Awesome. And then a couple things. I had mentioned that there is an error in your slide pack. It is on slide 17, which is this slide, and it's under the first bullet. And again, this is in the weeds, but you should at least know about this. Your billers do. When you bill advanced care planning services as a separate and identifiable service, that's CPT language, separate and identifiable on the same day as another E&M code, you use a modifier 25. So that can be used for any others. There is a different modifier for provision of advanced care planning services on the same day as an annual wellness visit. That's modifier 33. And it's important to get the right modifier because 33 is what allows the patient to get the service without an out-of-pocket cost. And then you can also, this is to say that you could bill this along with E&M codes in any setting, ED, home med visits, and transitional care management visits. The only exception is, the only time you cannot bill this on the same day is on the same day but by the same provider who is billing an intensive care code. So this is adult intensive care, this is pediatric intensive care, this is neonatal intensive care, because those payments are quite a bit higher, and advanced care planning is actually explicitly included in those services. Now, this restriction only applies to the provider who's billing the intensive care code. So clinical scenario, I'm a palliative care consultant. I'm asked to come see a patient in the intensive care unit for pain and goals of care. And I go in and we make pain recs and we spend an hour with the family. The intensivist would bill an intensive care code, cannot bill the advanced care planning code, even if they're in the room with me for the family meeting. I, however, as a consultant, am billing my own E&M code. I can bill advanced care planning because I'm not the one who is doing the intensive care. So those of you who run consult teams are still free to bill advanced care planning for consultations that occur in the ICU. You just cannot be an intensivist who reports the ICU code and also ACP. Does that make sense to folks in the room? Okay. Again, this stuff is way in the weeds, and I appreciate your rapt attention, but it makes a difference. Yes, go ahead. Microphone in the back.
So even though I'm in a hospital, I'm under a DRG for Medicare,
Yes.
you can still bill separately for the 99497 or 99498?
Yes, so really important. So the question was about DRGs. So remember that DRGs are the hospital-based payment that comes out of Part A of Medicare, we're talking now, or off the facility side for a private health plan. Well, what we're talking about in all the codes that we have described here are from Part B. So those are professional fee services. So those are meant to cover the time of the professional. So those are two separate parts of Medicare. So the answer to your question is yes. Where it gets a little bit tricky, and we'll get to this in the incident to rule, is that in the facility setting, the time and infrastructure of the non-qualified billers is expected to be paid for under the DRG. That's actually why the social workers and non-advanced practice nurses can't report these codes. Does that make sense? Yeah, so DRGs are meant to cover all kinds of things, right? So they're meant to cover the building, the materials, the lights, and frankly, the people, with the exception of the qualified health professional. So that all falls under Part A. Part B is only for the physicians and qualified health professionals. So that was a great question that I'm seeing nodding in the room, so I'm glad you brought that up. So what are the time requirements? As I said up front, 99497 covers the first 30 minutes of service, and 99498 each additional 30 minutes of service, and there is no limit. So if you have one of these, knock down, drag out, 2.5 hour family meetings, I've had more than a few of those over my time, you can add as many of these codes on as necessary to cover the time that's spent. Now, the documentation better substantiate reporting that, but you can do it. And this gets in, again, into a specific but really important piece of CPT convention. So time-based codes can be billed when the time spent passes the midpoint. So 1 minute past the midpoint of the interval. So for a 30-minute code, as soon as you spend 16 minutes, you can bill the code. And what that does is it sort of gives you intervals. So this next slide sort of gives you a sense of when you can bill what constellation of codes. So because it's a 30-minute code, if you only spend 10 minutes, you can't report the code. That is meant to be bundled into the evaluation and management service. You could consider stepping up a code, like if you're in the office and you would bill a level 3 code for a visit and you do 10 minutes of advanced care planning, that might help you get to a level 4. That's a different conversation. But you can't separately report ACP codes until you hit 16. And then if you spend 16 to 45 minutes, it's 99497. Well, once you hit 46 minutes, you can then start to add on one of the add-on codes to 99498. And then at 76 minutes, you can add on the second, and so on, and so forth. Does that make sense? And one of the questions that comes up, before we had advanced care planning codes, we had these things called prolonged services codes, if folks know what these are. I won't spend a lot of time here. Prolonged services codes were meant to sort of cover extremely time-intensive services. And frankly, palliative care teams, who often have very long visits, were among the most frequent users of prolonged services codes and still are. I make the point here on this slide, and it's super busy. The only thing I'll say is that it is worth, in almost all cases, using advanced care planning codes over prolonged services codes for the reason that the advanced care planning code, the base code's 30 minutes, and the prolonged services code is 60 minutes. So you can't start reporting the prolonged services code until 31 minutes, but you can start billing the advanced care planning code sooner. So what you'll see as you kind of look down the slide is that at almost any given time interval, the RVU reimbursement is higher for ACP than prolonged services until you get down to 136 minutes. And at that point, you need more than RVUs. You need a strong cup of your favorite beverage. But so ACP codes, there are other good reasons to bill ACP codes for these kinds of services that include being able to track it in the database. We know of at least 2 big R01 funded studies that are looking at the impact of ACP code delivery on Medicare service sort of patterns. That's important work to do. So use the ACP codes over the prolonged services codes. This is a question that was really important when the codes were developed, which was about frequency. So some people wanted to limit the advanced care planning codes to just once a year. At the annual visit, we would take time and sit down, update your advanced directives. We felt very strongly that that's just not how things work. People's lives and conditions change unpredictably, often day to day. So we were able to get some rule making that stated that there is no limit to the frequency of these codes. They can be billed daily, even if necessary. Now, that said, when it comes time to auditing, if you are billing ACP codes very frequently for a specific patient, that would be a flag for an auditor to come take a look. That doesn't mean that you're going to get in trouble. It just means that you need to be careful to describe what you're doing for the time it takes for the codes that you're reporting. Does that make sense? And then once a year, you do have available the ability to bill this without a copay at the annual wellness visit. So let's get to the incentive 2 rules because we've been talking about them a little bit. Incentive 2 rules are meant to kind of provide payment for services that are delivered by non-billing clinicians when under the supervision of a billing clinician, right? We've kind of talked about that a little bit to now. Yes?
Can you clarify what under supervision
yeah.
parameters are there?
Yep, we're absolutely going to get to that. This is primarily for Medicare fee-for-service. This does not always apply for Medicare Advantage plans who are getting a bit more creative in some commercial plans, but the incident 2 rules are kind of the standard. Really importantly, the physical location of the service has to take place in a hospital office. This is place of service 11 in the fee schedule. And this does not include, we had talked earlier about those hospital-owned outpatient departments. This does not include them, right? These are office practices that are independently owned. The service in Incident 2 is one that a physician or billing professional could provide but has delegated to a capable employee of their group. So the person who delivers the service has to have an employment relationship with the practice. They don't have to get a W-2, but they have to have either be a structured consultant, they have to have a contract. This is to prevent basically commercial vendors from gaming systems, because Incident 2 is available not just for ACP codes, but for a bunch of other stuff. So this employment requirement is a program in integrity or fraud prevention sort of mechanism. Now, to define supervision. Supervision means that a supervising physician must be available in person. So this is what we call direct supervision in the fee schedule. So if you're in an office setting and there is a ACP conversation happening with a respecting choices trained RN, there's gotta be a qualified professional in the building. They don't have to be working with that person. They have to be available to them, but they don't, and they don't have to see the patient, they don't have to be involved in the service, but they have to be in the building. They can't be 30 miles away at the home office. The service also has to be initiated or ordered by a qualified health provider. So one way that practices are executing this is when there is a physician or an NP or a PA who identifies a patient who could benefit from a more involved ACP conversation and says, you know what, I really want you to meet with Jessica, my social worker. My social worker is named Jessica. She's fantastic. And she can get you in, next Tuesday to sit down and really walk through this. And the patient agrees. Then I document that. Patient comes back the next day. Jessica does the entire face-to-face visit. I am not involved. I don't have to see the patient on that day. I don't have to be there. And actually, the supervising physician can be different than the ordering physician. So if the patient comes back on a day when I'm working up in the hospital and one of my partners is there or one of my NPs or PAs is there, that's just fine. So it's fairly flexible within this narrow confine of the office-based practice. If you are eligible to bill this, it's actually doable to set it up. And we know people who are succeeding in this. I'm going to stop here and make sure that makes sense. Yes?
And the billing, I'm wondering who the reimbursement goes to for that. You. Thank you.
Yeah, so it is going to go to the supervising physician. So this really probably works best in a practice setting where you've got a group of physicians, NPs, PAs, and then RC trained RNs, social workers, spiritual care providers who can do the work. But if you get it set up, and what some people are doing is they're initiating this at the annual wellness visit for their first steps conversations, and they can introduce this in about 30 seconds, and they've got workflow set up to get the folks on the schedule for their RC trained facilitated conversation. And as long as it's happening during business hours when someone from the practice is there, then that's able to be billed. Yes, in the back.
So I just want to clarify and make sure that I'm looking at the right direction. So we utilize volunteers, faith community nurses, things like that, that are trained as the facilitators. So if they have a contract with the clinic that says, I'll do X amount of dollars for every ACP facilitated for you, as long as the medical group is that it's an expense of the medical group.
Yes.
The facilitator, then the medical group can bill for the facilitator's work. So
I would take that question to whoever your billing professional is and just specifically clarify that with your MAC. But that sounds promising to me. The one thing I am not expert in the definitions of what the employment relationship is. I know that it can be a kind of a wage and salary. It can be a contractor relationship. The idea of paying people sort of per conversation, that may be one to bring in the lawyers on, or at least the compliance folks to make sure that they're okay with that. Okay.
I just want to add that tomorrow we've got a concurrent session where actually Betsy Payne, if you want to raise your hand, and you could talk to Betsy during breaks too, that they're doing something similar to that, and she can talk about that. It'll be tomorrow in that concurrent session. And then also Providence Health will be talking about how they're billing. And then in our workshop, we actually have a panel who is in the practice of doing incident to billing, so that they're going to actually tell their story about how they're actually doing that. So Amy got a question.
So if people see me on my phone, I want you to know that I'm tweeting live what's going on in here, because this is of broader interest, and Phil is my hero, and actually a hero to the field in this regard. So I could tell many stories of how heroic you are around payment and billing for these issues. So thank you, Phil. But I just wanted to kind of add a tack on maybe question, should it be audited? The notion of their title being volunteer, I would probably rethink that. Whatever, saying volunteer might be in direct conflict with there being a formal role.
Right. Yeah, I mean, Amy, who's comes at, of course, is Titan in the field, but also spends a little time with health plans as well, so has some instinct around that. I agree. The word volunteer really stopped me, and then you said people are getting paid. I think you probably do need to give them a more structured relationship with your practice. Mm-hmm. And that I would really sit down with your compliance team and help understand what that needs to look like in order to kind of survive audit.
Theoretically, it could be a contingent that is available to come to that place.
Yes, I think that has possibility. Right. Well, what's the relationship?
Right.
Yeah. I'll give it a different name.
I would just add, at Allina Health, we actually have created a job description for lay healthcare professionals called a care guide, and there's an actual job description, a pay grade, all those types of things. So it probably needs to be something official that you create within your system.
That's a great idea.
I just wanted to add that I just had this conversation with our state medical association, Washington Medical Association biller and coder expert.
Excellent.
And basically exactly what you're saying. If they are a non-paid volunteer, that you cannot have them do the work and the physician get paid. It has to be something to where the physician, it costs the practice something in order to bill for it. And so I think that, if it's a consultant, it's different. And so we're finding that we're using volunteers a lot more for group facilitations or different things like that, or for them even organizing paperwork and helping us with scheduling. But as far as the billing goes, it can't be a volunteer.
Yeah, and I think I used a really important word there. So I'm going to go, this group likes to get down in the weeds, so I'm going to go down to the roots. RVU actually stands for Resource-Based Relative Value Units. We actually don't use the word resource-based very often, but RBRVS is actually what that sounds like. And really the concept, and this is why the RBRVS system was at all, like why it was structured the way it does, is that it describes the resources required to deliver the service. CPT and RUC meetings are open to the public, so if anybody ever really needs some extra penance, or if you're coming up to Atone near Yom Kippur, come on by. You'll hear folks get down to, how much paper do I need to roll out on the exam table to freshen it up for the next patient? How many alcohol wipes to clean off? It gets way down in the weeds. But this idea, why I say that is that the resource has to cost the practice something. So you have to be able to assign a value to it in order for Medicare to pay for it. The fact that it's good and it does great things and is patient-centered is fantastic, but it also has to meet the letter of the regulation. Yes. This is great, by the way. I can do this all day.
Clarify, so our organization is an outpatient hospital, so does the facility-based billing.
Right.
Are we not eligible? We aren't billing now. Are we not eligible to do Incident 2 because of that now? We fall more under the hospital side.
Correct. You are not eligible to bill for Incident 2 as a hospital outpatient department because your place of service, 16, I think, not place of service 11. And the details, the concept behind that is that the extra payment that Medicare pays to your HOPD is meant to cover the cost of things like social workers and
we just switched this month, so great.
And all that kind of stuff. Now, one thing, and I know your leadership has a vision for this, Medicare's designs are actually to slash the payments to HOPDs to be far closer to what offices are. So that may open up future possibilities to broaden Incident 2. That's a separate conversation for a separate day. But that's why you're not eligible for the same reason that hospital-based services are not eligible for Incident 2, because the facility payments are high enough that they're designed to cover the cost of the people who in your case, are delivering the services. Great questions. So it's smart, thoughtful group. Come on over here. Yeah.
And this says physician. It can be a clinician that's providing that employee that is providing that
PC conversation?
Correct. Thank you for that. I did it up front a little bit, but the slides become so busy. Every place that I put a physician here, add and qualified health professional. So that means advanced practice nurses and physician assistants working under the relevant state guidelines. Because remember, scope of practice is different state to state. So what you need to do for your docs to supervise your APPs is just know your state. But
they just need to have established some sort of plan of care.
Right.
They can't, walk in off the street and say, oh, you should do ACP. They have to know them and establish a plan of care first.
Yeah. Excellent. Great questions. Anything else over here?
I have a question about the incident too, and the fact that right now, the way we're interpreting it is the conversation does need to occur within the doctor's office, so to speak, right?
Yes.
Which leaves our chronic, non-mobile patients out of that. So I'm wondering, do you see movement down the road?
That's a great question.
Of expanding incident to cover that, because it's a population that desperately needs those conversations.
I could not agree more. So let's all geek out for a second here on policy. That gap is huge, and we know it. This really only helps the people who can come into the office. As part of the most recent Budget Act, some language was slid in that asked the Government Accountability Office to look at some codes for what we're calling longitudinal care planning, which could open the door to pay for different kinds of services. We'd still need to get past the rules and the fee schedule, which are really what govern this, but a statutory fix, meaning a new law that would amend the Social Security Act to sort of change that, is a possibility. So the GAO is studying this now. We've been encouraging that they're talking to groups, they've talked to us, we've asked them to talk elsewhere. We gave them Respecting Choices name, we want them to talk with you guys. But because I think this is a problem that needs to be solved. So I went deep first to say that I think there's an opening, but it's gonna require a statutory or a new law. This is not near term. This is dog years, unfortunately. But all this. I mean, this started in 2013, right? And we're here in 2018. So there's never a reason not to keep trying. Yes.
So I just want to clarify. So home health.
Yes.
Can't have advanced care planning conversations and bill for that as far as incident 2?
Right.
Is that correct?
Incident 2 only applies in places
in
of Service
office
11, which is an independently owned office.
Okay.
Non-hospital owned office.
So with the sort of caveat that it must be face-to-face, are they considering telehealth?
Great foreshadowing. We're going to get to that. And
okay.
I don't want to stunt discussion because this is fantastic. We've got about 3 minutes. I'm going to jump ahead a little bit. We've actually covered a fair amount of this content on the slides with your excellent questions. I mean, you sort of led us through this conversation. It's a fantastic group. Let me just take this, the place of service. We've talked about this a lot. The idea, and again, we talked about this a little bit, so deductibles and coinsurance apply to this. Now, some patients are responsible for a lot of that with high deductible plans if they don't have Medigap insurance. However, a lot of beneficiaries do have something that covers the gap, or they have an Advantage plan. So they will get a copay potentially for this, but they won't be responsible for the full 20% of the service. So you need to be alert to that, which is why we tend to be the combination of that, and also the fact that the time thresholds for meeting this service occur not every day for everybody, right? About 0.78% of Medicare beneficiaries have this. It's right now concentrated on folks who's sick. Make this real and something to be aware of, though done reasonably enough, it usually, we haven't gotten a lot of feedback of concern from patients and families. Yes. Yes.
Copay with the Medicare Advantage.
Yes.
Can the organization, if they do so, waive that copay?
That's a good question. I think, and this is, I'm going to unfortunately punt that because I don't want to speak where I don't have high certainty. I believe in Advantage programs. There are certain places where that can happen, but I would definitely check with the parts of your organization who know that. That cannot happen in traditional Medicare. So traditional Medicare has strict rules around that.
I'm aware of a health system in Michigan that they audited their charts and they realized that the number of patients that would end up having to pay a copay was very small, so they waived it.
Yeah.
They just eat the cost.
So there may be some precedent for that. So I would talk to your organization. Yeah, but I think you have to have a waiver and it has to be in place.
You have to notify the
Right.
patient that there is a copay, but that you're gonna
waive it as an organization. And I'll further check into that because Kaiser Permanente in Colorado does not charge bill for ACP, so we basically do what we want, but
That's
now
fantastic.
we're investigating and exploring how to do this, and one of the concerns is the Medicare Advantage. We have a decent population of them having to pay that copay and them refusing to do ACP because of copay.
Right. So Kaiser, as both a health plan and a health provider, has that flexibility for its own population. But I think it's definitely important to reach out pair to pair. So in our last just minute or so, I'm going to talk about telehealth. So starting in 2018, Medicare is now making payment for advanced care planning services delivered via telehealth. Now, is anybody doing telehealth anywhere? Great. So you probably know that the current rules for telehealth are a small step in the right direction, but don't get anywhere near there. So to bill a telehealth visit today through Medicare fee-for-service, the patient has to live in a healthcare shortage area, effectively, and they need to go to what's called an originating site. It's usually a clinic or something near their home. There has to be an established real-time telecommunications technology that they'd be able to see and hear the person. So that has had some advantages, certainly being able to deliver subspecialty care. I mean, we have a bunch of subspecialists at U of M. They do telehealth up in the UP with the docs up there for patients who need expert consultation from a gastroenterologist or from a neurologist. So that's great. But for patients who are frail, elder, sick, have a hard time getting out of the house, getting out of the house to go to some clinic is not any easier than getting out of the house to come to see you. So you specifically cannot yet do things like a secure video visit with a patient at home through the fee schedule. I will tell you there's a lot of interest in changing this rule, and there's actually some language out there in some proposed rulemaking to be able to liberalize this significantly. We know of a lot of demonstration projects and a lot of Medicare Advantage plans who are enabling video visits at home for serious illness care, and it's been incredibly effective. Some of you may know Dana Lusbader and her work in near suburban Long Island with ProHealth. They heavily use a model where they've got a skilled healthcare worker in the home, sometimes an LPN, occasionally an RN, with a video visit back with the physician on the team. The technology that they use also allows multiple family members to join the chat. So everybody is sort of on the same video visit together. It's very effective. So that stuff may be coming. Today, however, if you can bill under the current telehealth rules, you can bill advanced care planning. Okay? Excellent.
I have one last question, if it's okay.
Yeah.
So you had shown how things have almost doubled in the frequency of advanced care planning billing in reference that we're 3/4 of the way there, because 1% of people really we would expect to have this conversation.
Yeah.
My question is, how long does a CPT code live, quote, before it's sunsetted because it's not active enough?
Oh,
and does that ever happen?
Yes. Won't happen with this. I mean, these are being used hundreds of thousands of times. The ones that are low volume codes get used, 1,000 times a year or less, right? These are usually very picky procedures that only like 4 ophthalmologists do twice a year. So we're in no danger of that. What will happen though is that every CPT code, after it's been out for 4 years, I think, goes through a review. And we're anticipating that in the next sort of year and a half. And there's a whole process by which we look at code frequency, code location, code integrity. So that process, usually the first time a code gets reviewed, which will be this one's first one, that's generally used as a learning opportunity. They don't change the code much, but there will be ongoing monitoring by CMS and CPT and the RUC kind of in partnership, as they do with all codes.
Okay. So now's the time to really get going and try to start using it so that that we can actually shape this code as it goes forward. So
excellent.
Phil, thank you so much for your time.
You all. This was fantastic. You're the best audience to date that I've worked with.